Thank you, Jaspreet, for conducting this very beautiful webinar on a topic that's very difficult. At least for me, I find it very difficult. So, Dr. Jaspreet has given me a topic on infective optic neuropathy. So, we all know that optic nerve is vulnerable to a variety of insults and infection, and Dr. Diksha very elegantly showed us there could be different causes for optic neuritis, and infection is one of those. Now, when we talk of infections, there are some very typical infections which I have labeled as horses, like tuberculosis, cat scratch, Lyme, syphilis, CMV. Now, these are the kind of infections which you should be suspecting. Malaria, maybe you don't see it that commonly. I'm in the optic involvement. Then there are zebras. Zebras are basically the very non-specific presentations where you have to have a very high index of suspicion, and these are very unusual conditions. So let me take you over to some of these infections. When we talk of tuberculosis, tuberculous involvement of the optic nerve head generally occurs because there is involvement of adjacent retina and choroid. So it's very important to look, like if you look only in this area, you would think there is an optic neuritis going on. But learn to look dilated fundus and look for lesions in the periphery, which may be just patchy vasculitis like this, are more characteristic choroidal granulomas are patches of choroiditis. So once you see this, this is very typical, either TB or sarcoid, but I'm not discussing sarcoid. So think about tuberculosis in these situations. You do the fluorescein and these spots will appear, they will show beautifully as hyper to hyper, and you know what you are dealing with is not just simple optic neuritis, and go ahead with the lab investigations. Other disease, other infection which we see rather commonly is the cat scratch disease. Just remember that cat scratch causes neuroretinitis. So you may be seeing optic disc edema like this, but very classically you will see a star which is centered around the fovea, and typically it might result in a complete star. This is caused by the organism Bartonella. So Bartonella generally affects children and young adults, acute visual loss, unilaterality. Unilaterality is very common. There may be some history and you see white lesions. Very importantly, for example, in this patient, a young girl, you may have a cat scratch disease, but it's very important that you may have associated vascular occlusion. So if you are seeing your optic neuritis with vascular occlusions like this, and this may be progressive, another occlusion developing another site, think of cat scratch as a possibility. There is also predilection for capillary proliferation, retinitis, and treatment. Generally, it's self-resolving, and also important that history of exposure to cat is not necessary always. Self-limiting, number of antibiotics have been tried, so if you wish, you could try those. Syphilis is a great mimicker. So when optic nerve gets involved in the syphilis, it could be anterior or retrobulbar or neuroretinitis, generally in the secondary or tertiary syphilis. And testing is important. Anytime you see optic disc edema with inflammation, syphilis always needs to be ruled out. And CDC recommends that you screen with non-treponemal lab test and then confirm it with treponemal test. Remember, if you have syphilis, always treat as neurosyphilis. Now, this is an example of a patient, 43-year-old man, who was actually diagnosed as papilledema elsewhere, but he had these some vitreous cells, came out to be positive for syphilis, and this is how you treat it. The treatment is with penicillin injectable like neurosyphilis, and you can see the resolution of optic neuritis. Viruses are another very important causes. Optic neuropathy in herpes virus, both type 1 and type 2, may occur in association with retinal necrosis and very rarely with herpes encephalitis. So, optic nerve involvement may be either concomitant or actually follow the retinal infection. Now, this is the kind of the infective viral which is seen in herpes. Now, this is the patient with on, and if you look in the periphery, you will find these lesions in the periphery, which are necrotic retinitis. So, anytime you see the disc, which doesn't appear just simple swollen, you are seeing some whitish infiltrates, yellowish white, either involving the optic nerve or the adjacent retina, or there is a macular scar and you have vitreous cells associated with this. These are all the conditions where you would suspect infections to be there. Another common infection which we all see is toxoplasmosis, which may present as isolated papillitis or juxtapapillary papillitis, or there may be distant chorioretinitis. It is very commonly seen in atypical form of toxoplasmosis in the immunocompromised patient. Now, this is an example of a patient who has optic nerve involvement. You can see bilaterality with vitreous cells, counting finger in the right eye, and he is also HIV positive with CD4 count of 95. So we were not, honestly, it's not really toxo like a horse, like it's not written on your face. So we did the diagnostic PPV, which showed a Toxoplasma B1 gene, and the patient was treated with anti-toxo treatment, and you can see the resolution and the healing of the lesion now 9 months later. Cryptococcus is another disease, and these days it is actually mucor. I could not find a picture of mucor, but I have put in a picture of cryptococcus just to indicate how fungus could present as infective form of optic neuropathy. So cryptococcal disease may cause papilledema due to meningitis caused by cryptococcal neoformans, especially HIV patient. And these are the kind of the patient. I'm not saying you suspect cryptococcus in every patient, but if the patient is coming to you in a setting of HIV with opportunistic infection and you're suspecting some of these are the kind of the patients you should be looking for. Finally, rickettsia, which is again a zoonotic disease, not that we see it in day-to-day practice, but if you happen to have a patient who has been to area where these kind of infections are prevalent, and since these days, well, at least pre-COVID days, the traveling is so rampant, so you've got to keep these in mind. So the diagnosis is basically based on epidemiological data, systemic disease, ocular involvement. It is by and large self-limiting. You may not really have to diagnose it, but if required, PCR. And this is following treatment of doxycycline, but you can just not treat also, even then it will respond. So to conclude, infective forms of optic neuropathies can resemble very closely non-infective forms, but there will be certain clues, and try to look for those very few vitreous cells which might be there, some yellowish white lesions around the optic nerve head or even away from the optic nerve head. Always dilate and see the periphery to see what is happening elsewhere in the retina. So it's important, in short, to have a very high index of suspicion. And thank you very much, Dr. Jasprit, once again.